Hi, my name is Ali, and today I'll be presenting the topic of Hashimoto encephalopathy and use a very interesting case that we saw in our clinic to demonstrate the diagnosis, the management, and the treatment of this very rare condition. So let's start with the definition and the diagnosis. So Hashimoto encephalopathy, also known as steroid-responsive encephalopathy associated with autoimmune thyroiditis, is a syndrome of neurologic symptoms associated with autoimmune thyroiditis. So we see a constellation of symptoms, including ataxia, myoclonus. Patients often have marked cognitive impairment, such as confusion, difficulties word finding, and these kinds of symptoms. So Dr. Grouse and his colleagues devised diagnostic criteria for the syndrome, which must all be met. So as I said, there's the encephalopathy-like syndrome, which also includes seizures, hallucinations, stroke-like episodes. And these patients typically have subclinical or mild thyroid disease, and they must have positive antithyroid peroxidase or thyroglobulin antibodies. But like I said, they're going to be typically euthyroid or will have subclinical or mild thyroid disease. Then we perform brain imaging, and the MRI of the brain must be normal or have non-specific abnormalities. And they should also have an absence of well-characterized neuronal antibodies in the serum and the cerebrospinal fluid. What's also very important is that this is a diagnosis of exclusion, and other causes of encephalopathy should be excluded as well, such as antibodies for autoimmune limbic encephalitis, metabolic abnormalities such as urea with kidney disease or ammonia with hepatic encephalopathy. So before we come to this diagnosis of Hashimoto encephalopathy, it's very important that we exclude the other more common causes first. The last thing is that patients very typically improve after the administration of steroids, and this is very suggestive of the condition in the setting of all of the things I've just mentioned. So what is the pathophysiology? The answer is we don't know the pathophysiology. Patients are typically euthyroid, and though antithyroid antibodies are typically common, we don't necessarily see a direct link between how they cause a central nervous system damage. So all we can really do is identify the clinical syndrome that patients present with, but we're still unsure on how exactly the damage occurs and why they're occurring. So how do we manage Hashimoto encephalopathy? So as I mentioned before, it's a diagnosis of exclusion, which means that there's an extensive workup that must be done before we actually diagnose the condition. So other autoimmune causes should be investigated in the blood, serum antibodies, and things like that. Structural anomalies should also be ruled out, the MRI of the brain that I mentioned earlier. EEG should be done, especially in patients with seizures, myoclonic jerking, and a comprehensive metabolic workup should also be considered, also because of the things I mentioned earlier, urea, ammonia, these kinds of things. So after we form the provisional diagnosis by ruling out these other conditions, finding the antibodies and such, the first line treatment of Hashimoto encephalopathy is corticosteroids. And patients usually experience resolution of the symptoms with corticosteroids, although some patients are not always responsive to these. And in these patients, we should consider other autoimmune regulators according to the literature. And some of the options that we've investigated are azathioprine, methotrexate, and IVIG. In the clinic, we previously saw a case where they had ataxia with Hashimoto encephalopathy, and they were unresponsive to steroids, experienced relapses, and their symptoms resolved using IVIG. So let's move on to the case that we saw in these recent weeks. So the patient's chief complaint, she was a 45-year-old female presenting to the clinic following 4 months of whole body jerks. And these jerks would really disturb her. She experienced about 50 per day. It would bother her during the entire day, during her sleep. She did describe this kind of buildup of energy that would leave her very exhausted after. Initially, she also described memory problems, headaches, word finding difficulties, but otherwise, she had no other neurologic deficits. So She didn't experience any loss of consciousness, no tongue biting, weakness, tingling, numbness, anything that would help us localize the cause, nothing like that. Her past medical history is pretty unremarkable. So she only had esophagitis, which she was treated with a PPI. And she also experienced many COVID-19 infections, including a severe one that included myocarditis. And she said that her symptoms worsened after this. And there have been some instances in the literature where COVID-19 can trigger this condition, which is interesting. Otherwise, unremarkable family history. So let's get into the workup in the labs that I described earlier. So vitals, normal vitals for the most part. Her pulse, 69 beats per minute, that's normal. Blood pressure slightly elevated, but none of these very suggestive of thyroid. So as I said earlier, subclinical mild thyroid. MRI of the brain with and without contrast, unremarkable. 20-minute EEG, no epileptiform discharges. Her nerve conduction studies, EMG, unremarkable. We also performed a blood serum analysis entailing cell counts, lipid profile, a metabolic panel, LFTs, which all came back unremarkable. We also, in the autoimmune workup, she did have positive anti-nuclear antibodies, but other autoimmune diseases such as the ANCA vasculitises, the double-stranded DNA for lupus, and toxic metabolites, these things were ruled out. Most importantly, she had elevated antithyroid peroxidase and antithyroglobulin antibodies. However, her thyroid function tests showed no abnormalities. All of her values were within normal range, coming back to the idea of them being euthyroid. Following that, the patient was seen months later to go over her results. She did a 72-hour EEG to further evaluate the myoclonic jerking, which was unremarkable. Her thyroid profile was again unremarkable. And this time in the blood serum analysis, we repeated it. Her anti-nuclear antibody was negative. So how do we get into managing this patient then? So this patient was initiated on a 4 milligram methylprednisolone dose pack. So she would start with high dose of steroids and taper down throughout 2 weeks. So after 1 week, she reported a reduction in her whole body jerks from 50 jerks to 10 per day. The cognitive symptoms that I mentioned earlier, the word finding difficulties, the confusion, those resolved without treatment in between visits. The antithyroid peroxidase antibody levels were reduced to normal after 1 week of treatment. However, the antithyroglobulin levels remained slightly elevated, but regardless, they were reduced significantly as well. And after 2 weeks of treatment, she reported just 2 jerks per day. So this patient, she meets all the criteria. She was responsive to steroids. So we feel pretty confident that this diagnosis of Hashimoto encephalopathy was spot on. So what's the conclusion and what do we want to take from this presentation and even the case? So patients with encephalopathy-like symptoms of unknown etiology should receive a comprehensive metabolic evaluation, including antithyroid antibodies. So this condition is very rare, but because we did an extensive workout and we ruled out other conditions, and then the doctor, he saw a case of this before and he said, hey, we should do thyroid function tests and evaluate for antithyroid antibodies. By doing that, we were able to reach the Hashimoto encephalopathy diagnosis and successfully reach a conclusion for this patient who was experiencing very debilitating symptoms. So, and Hashimoto encephalitis tends to improve after a trial of corticosteroids, like I mentioned. So my aim of this presentation is that I want to spread, or at least inform everyone how thyroid peroxidase antithyroid antibody testing can be highly significant in cases of encephalitis of unknown etiology. And here are my references. Thank you for listening to the presentation.